Before we start, can I just remind everybody that the meeting is being recorded and will be placed on websites for public viewing. And I'll now do a roll call for the minute. Councillor Lynn.
Present.
Bob Benson.
Present.
Councillor Toland.
Hi, I am here.
Councillor McHugh.
Present.
David Cheap.
Present, yes.
Colleen Carleton.
Present. Morning.
I've had apologies from Glenn Lloyd, Dave Berry,
Present, Harvey.
Justine Jones. Present. David Wilson.
Good morning, present.
Apologies from James Smith and Sanjay Pillai, Raymond Marshall, Jim McFarlane and Christina Cooper. However, Anita's here for Christina. Martin Sloan. Present. David Shaw.
Present.
That concludes the roll call. Chair, will just carry on?
Yes. Go ahead.
Item 1, apologies, which are already noted. Item 2, declaration of interest. Are there any declarations? There being no declarations, we've been asked to take item 12, which is NHS Tayside GP out of our service strategic framework next.
Okay, so, sorry.
As I say, so we can just,
Yes, sure, sorry.
Lost sound.
so I just lost just for a second, so, but he's back in the room, so I'll just actually pass on to Jill and Scott, if you want to kind of just take us through some of the key themes from the report for new members.
Yeah, thank you, Dave, and thank you, Chair, for accommodating us earlier on in the agenda. So I'm Gillian Galway, Chief Officer in Angus, and I'm also joined today by Dr. Scott Jameson, who's the Associate Medical Director in Angus Health and Social Care Partnership, also who has had that kind of clinical lead role in this piece of work. The members will have had the papers and the associated documents, so I'm not going to go through them word by word or page by page, but this paper comes forward to the IJB as a follow-on from the joint development session which we held in October, and that was across all 3 IJBs in relation to the out of hours reform. And that at that session we explored the emerging strategic direction for the GP out of our service, and reflected collectively on the system challenges, the learning from tests of changes that were presented, and what the opportunities were for that whole system reform. As members will be aware, Angus IJB holds the lead partner responsibility for the strategic coordination, as well as the operational responsibility for the GP out of our service on behalf of NHS Tayside. This strategic framework has been developed collaboratively with Dundee and Perth and Kinross Health and Social Care Partnerships and other key stakeholders, including NHS24, Scottish Ambulance Service, as well as engagement with the public and public partners, who've all supported and informed the direction of travel. In line with the current integration scheme, all 3 IJBs are required to consider and approve the strategic direction to ensure consistency, alignment and shared ownership across the region. So the framework presented today sets out a clear evidence-based direction of travel for the next decade, which has been shaped by engagement and feedback, as I've mentioned earlier. And really builds on the principles of the service renewal framework, which was published in June this year. So the paper seeks approval from Dundee IJB to formally adopt the strategic framework, and obviously to then support Angus to issue the direction to NHS Tayside, which will enable the next phase of work around developing detailed co-designed service model options through a structured and transparent appraisal process. Happy to take any questions or reflections, Chair, and I don't know if Scott wants to add anything to what I've said.
Jill, thank you so much. Good morning, members. Yeah, I think well, if you were going to, if you were skimming this for the first time, which I'm sure none of you are, but page 5 of that paper about the strategic framework really hopefully helps capture everything there, as it's termed, the plan on a page. And hopefully people read through that and can fully get behind it. It is very much those kind of motherhood and apple pie type principles of a safe, sustainable, person-centred out of our service. It brings together a skilled multidisciplinary team providing high quality compassionate care close to home, and you know, that's hopefully resonates with everybody around the table, and the challenges of doing so and operationalizing that will be the next stage and how we do that. But for today, it's about agreeing what those principles are that are going to guide us around that, and that will directly inform how we then assess how that will look going forward and how it will cope with the challenges of the next 10 years that are facing us in an older, frailer, more complex population, and how do we resource that correctly as well. So yeah, I think clinically it resonates with staff and with our public, and hopefully with members too today.
Thanks, Scott.
Yeah, thanks very much, Johnny and Scott, for your presentation. Clearly, this is a very important paper because sudden illness doesn't respect surgery, and that's really important that the out-of-hours service is as effective as it can be. I have one question thus far from Bob Benson.
And thanks very much indeed. It's an excellent paper, and thank you, Gillian and Scott. And I'm really taken with the the whole collaborative input into this, which is clearly looking at not just the work of the services within Tayside, but also our partners in NHS 24 and Scottish Ambulance Service, and indeed pharmacy as well as our GPs. So this is an excellent study piece, I think, for our audit to actually have a good look at how this collaboration will actually work in practice. And I think we should think about it in that frame as well, because we want to get some good feedback from internal audit on how collaborative this is working in practice. And that's a key area that we want to look at in future. I would think a lot of positives will come out of that, but I do think there's a lot of learning needs to come out of it as well. I think one of the keys for me are going to be how we engage the public and communities with their understanding of this whole approach. And although we may understand it internally, how are the public going to understand this? Because they have different views about who's the most important service to go to. Invariably, they will go to the GP, but often a pharmacy might be a better approach as well, or indeed a service that might be delivered by an advanced practice nurse, for example, or we could be looking at Scottish Ambulance Service dealing with cases on the ground, actually outside someone's house. So I'd be really interested to see how confident you feel that that area can be delivered that would give the public reassurance. And just a segue into that as well, you did talk about co-design, Jill. I take that to be co-production. Is that the same word?
Co-design and co-production, Bob, yeah.
Yeah, thank you. So I'm assuming that somewhere or other the public, or in particular thinking about service users and our carers, actually have some input into this in some form and with their network groups. So thank you.
Yeah, thanks, Bob, and I will bring Scott in on this as well. There's quite a lot in what you've said there. So there's what's in our sphere of influence in terms of that co-designing and co-production, and the papers do include our current preliminary statement of engagement, and that details the work that we've done around engagement. The public part of that is twofold. So we've been working closely with the NHS Tayside public partners, and we've also done that wider public survey, and that does include service user reps as well as our carer reps to seek their views. And the feedback from the survey, which we did share at the development session, has really heavily informed that vision and the strategic direction for us. And we will continue to work and engage with public and public participation group, as well as our carer reps as well, who we absolutely recognise are immensely important in that whole drive to support and care for people closer to home. In terms of the future engagement, we will continue through the options appraisal work. We're also working very closely with Health Improvement Scotland around the engagement of this, and it does take a similar line around what we did with the minor injury review, and Health Improvement Scotland has held that up as an excellent piece of work in terms of how we engage and work with our public. So we will continue to do that engagement going forward to co-produce and co-design the models. The challenge we have around that is both around expectation and the messaging of who best to see when. Scott and I are privileged enough to be part of a CFSD, which is the Centre for Change and Sustainability Delivery. That's probably the wrong terminology, but we've got 3 days, 1 day last week and 2 days yesterday and today with CFSD, specifically looking at our urgent and unscheduled pathways. And part of the discussion yesterday was absolutely that, Bob, around how do we align our local communication with the national communication so that people know where to go, who best to see and when best to seek that help, so that people are getting the right care at the right time in the right place by the right professional as well. So that's been part of that, but I will see if Scott wants to add anything to that.
Yeah, thanks, Jill, and thanks for the question, Bob. So it's a really good one. It comes up a lot, actually, and people will ask us about that. When you ask the public on the cold light of day, who do they want to see? They always say they want to see the most qualified professionals close to their home as they can possibly get it. And that includes, I want a stroke consultant in the back end of Montrose. But that's exactly what everybody would want. Why would you answer any differently, if that makes sense? Actually, when people see advanced nurse practitioners, for example, you raised a specific example, we have done some work to look at that. And they really, really did not mind who they saw, as long as the person they saw was capable, competent, and delivered the care that they needed in a timely way and in a way that's best meets their needs. A person will only contact out of hours once every 5 years or so on average. So we have real difficulty in messaging something in advance that something might happen in 5 years, that in 5 years that if you have an eye condition, do you know you can go to your local community optometrist, even if you're not registered with them, and they will see you about your acute eye issue. Now, that's not something that everybody will immediately know. It doesn't matter. What does matter is when you then go and say, oh, my eye's really a problem, I'm just going to nip into the pharmacy. We need a seamless line from that community pharmacy straight into the local optometrist or from your GP, that the person says, that looks really sore. No wonder you're popped in to see me. But you know what? I'm going to give this person a quick call and they'll see you. Oh, they're free at 10 o'clock. If you pop into the optometrist at 10 o'clock, they will have a look at that eye for you and check what's going on. Oh, thanks very much. That's really good. And the optometrist gives an excellent assessment of that acute eye issue and can refer you directly to hospital if you need to be. So we work really hard on those pathways, appreciating that people don't always know where to go, that they won't always remember that advert that they saw 2 years ago. That's fine. We work really hard to make sure that wherever you pitch up, we'll try and hint, we'll try and give advice, we'll try and give things in advance, but we know that it's not always right. We know you won't always remember, but we do have great care navigation across practices, community pharmacy, optometry. We all work really closely together so that it's a very integrated healthcare system, the most integrated healthcare system I would reference probably in the world. You just don't see this in other places because we are all under that NHS umbrella. That means that we can deliver that care really seamlessly. So yes, it comes up, but we're reasonably good at dealing with it.
If I may, Chair, just a supplement, if that's okay. Just to say is that You refer to shared resources within the document. Does that suggest some kind of contractual understanding between you, that there is an expectation that if there are financial or other inputs that are required here, that sounds like a kind of memorandum of understanding at the very least for me, in terms of that the expectations of each of these partner agencies?
So it doesn't specifically mean just the independent contractors, Bob. What we need to look at is how we best use the resource across Tayside, and that's not just from a health and social care partnership perspective either. It also includes obviously our acute services alongside that. So part of the next phase, when we look at the models, will be absolutely to have that financial framework around that, so that if there is any either shared or shift of resources that would be required to support that whole urgent and unscheduled care pathway, then we will have the financial framework in place to support that. And just a bit of the kind of verbal feedback from yesterday's CFSD visit, and we've got people from all over Scotland taking part in that, and the feedback yesterday was they have never been to a place where everybody is so joined up in relation to urgent and unscheduled care as what they have seen yesterday, as part of both the presentation and the visits yesterday afternoon. And I think we need to take a lot of praise around that, because they've done, I think, 8 visits so far across a number of different health board areas, and we are the first ones where we've included our primary care colleagues, as well as out of hours, as well as ED, as well as our acute receiving units as part of that whole unscheduled pathway. And we include optometry, dental, etc. as part of that, who also support us in dealing with urgent and unscheduled care. So it's wider than just the independent contractors, Bob. We do need to look at that wider financial framework to support whatever model of care we decide is the preferred option and bring back around. That's what we're aiming to do, and here's how the resource will work around that.
That's so heartening. Thank you so much, Gillian. Thank you, Scott.
Yes, and next up, Ms. Dorothy.
Thank you. I have a question relating to risk assessment, section item 6 in the report. The inherent risk level is scored at 25, which is extreme. And I would just like to ask, how confident are we that the mitigations listed will reduce the risk level to 12, the planned risk level?
Okay, Dave, is that in your cover report?
Yes, so I was
Yeah.
pick that one up because that would be kind of our own assessment of where we are. I think in terms of how John Scott just kind of described what the kind of the plan of action is, and the kind of vision around this, that kind of sets out quite a clear direction of travel, which is different from where we've been. I think given that kind of whole system approach that's been described as well, that kind of helps. Excuse me, helps to kind of. We're not working on this big challenge in isolation, so it's going to bring the totality of the resources. So the risk that's been identified as a risk of improving population health outcomes. Obviously, specifically for us in terms of the population of Dundee, what's been described in terms of the framework of the model is what then gives us the kind of confidence. Yes, things will change because things have to change in terms of that. It's not sustainable model, and that's why we're going to make that assessment around that reduced risk.
Okay, thank you. I mean, I did hear about the financial framework that's coming. It's just that the mitigating actions here only talk about discussions regarding the planned progress and support through reference to financial framework.
Yeah, so yeah, financial framework element is obviously a challenge. That will be, I think, for us, the next step around this. So when we have the new model of care that's been set, but we can it's the new on. the financial side of things will come more into that, because the payment service will have the principles, etc.
Thank you. Sorry to put you down, but on what's obviously, a good piece of work, but it's ongoing. But considering we're moving into budget phase, this is where my mind is focused. Thank you.
Yeah, I think all of us are very focused on the upcoming budget. Before I move, there's no other hands up. I noticed that David, just after 10 o'clock, you said the sound quality was very good. Has it improved?
Yes, it has, Ken. Maybe because you're furthest away at the room and you're a bit less clear than the rest, but I'm getting it. Okay, thank you.
So, yeah, thanks very much for coming along to speak to the paper. Can we accept the recommendation from 2.1 to 2.3 to note the progress, to approve the service strategic framework, and to instruct the Chief Officer to advise Angus IJB of our decision? That agree? Saying thank you.
Thank you very much.
Yeah, thank you for coming along.
Thank you.
Thanks, everyone.
That takes us back then to item 3A, which is the minute of the previous meeting held on the 16th of October and is submitted for approval.
Any matters arising or inaccuracies that anyone would like to point out from that minute? You happy to agree the minute of the last meeting? Yeah, thank you.
That takes us on to 3B, which is the action tracker.
Yes, indeed. No, I should have had my copy of the column from it, but yeah. Any questions from this? Have any questions? It seems quite straightforward. Complete. Some ongoing and progress. I see no. Yes, I see one hand on option here.
Item 10, financial monitoring position, and it's noted that there's issues with current resources. Is that staffing levels, Dave, that you're not able to? Although information is provided by it's about absence levels, absence of analysis.
Yeah, so absolutely. So that's what coming.
Yeah, Dorothy, it's essentially, so we get our access information into different formats from the different organisations. It takes significant resources to calculate those that are going to be merged or to be compatible. And we just don't have that resource available to do that. It's not that we might never be able to do it, but right now in the future budget setting and other priorities, we're not in a position to be able to fix that.
Okay, thank you. That's fine.
Thank you.
So when we look at the absence stats for NHS side staff and for Dundee City Council staff, they're not necessarily comparable with.
The provided is one that's full time equivalents, one's full time equivalents, which sounds like it should be compatible, but it's technical and that, so it takes some recalculation background to be able to do that. We also get data at different levels, Ken, so we get more detailed information from Dundee City Council than we do from NHS side in terms of being able, essentially we have the raw data from Dundee City Council, which would allow us to recalculate on that side of things, but we don't have the equivalent from NHS side. We have to ask them to do that on our behalf, and that's just something they can routinely provide.
It's a piece of work.
Yeah.
The two sets of information come from the two partner bodies, and they are consistent from with the council.
Yes.
Reporting methodology, NHS reporting methodology. Yeah. So if we were to ask them to do something specific for the social care partnership, we need to ask both sides to do something different from what they're currently reporting corporately for the rest of the organisation. Yeah. Okay.
So yeah, next item, please.
It's item 4, which is an agenda note on housing with care, and you're asked to approve the direction.
Yes, this one up. So we get before standards for this bit of apology to the IJB because we made a mistake with the housing with care report that was submitted in August. There should be a direction to Dundee City Council to anticipate that, and whether the IJB approved the recommendations within that report, which were around changing the model of housing care, because of the direction attached to it, legally we could not then direct the chief executive of the city council to instigate changes that we'd already agreed. So this is just going to come to light now as we could make some further progress in terms of the changes, and therefore it is a retrospective request to kind of approve in the direction that should have been attached to the title. So
that's kind of technical level. So we approved the item, the changes, but couldn't it just have been taken as read, really, that we'd authorised direction if that was what was required to take it forward?
So after
Not after the go,
not at all, after consultation with Roger Many, in terms of the kind of not the authority, a delegate authority in particular, it was deemed that we did not have the authority to do that without some action directions, which is why we asked to see if it was amended today.
Are we happy to agree with? Yep, thanks for that.
That takes us on to item 5, performance and audit committee chair's assurance report, which is submitted for information and learning purposes.
Well, I know that the last meeting had to be had to be rescheduled, so I'd like to thank everyone who helped out by including yourself, of course, as chair, Bob, by rescheduling that so quickly. Was there any comments you'd like to make in relation to your assurance report, Bob?
No, thank you, Ken. I think the paper is self-explanatory. I'm happy to take any questions on it.
Any questions? I should say it's very straightforward, so thank you for that.
Item 6, IJB membership, service user and carer representation. You have this for a decision.
Apologies because I realised that the report's actually dropped off at some point in the meeting process. So the purpose is to propose the IJB approach both in the short term and longer term around the identification, appointment and succession planning for our lived experience representatives on the IJB. I'll not say too much about the paper, it's fairly self-explanatory, but just to note that the strategic planning advisory group has given this issue quite significant consideration for a number of meetings towards the last year, including input from Martin as the carers rep IJB, but he's also a member of the strategic planning group as well. Obviously, the report highlights that this is a challenge across the country. We've got to think carefully about what makes sense for us in Dundee, to do looking at some of the best practice from other areas, but also our local arrangements. So in summary, in short term, we are proposing that we move ahead with an appointment to the vacant service user position from the DH&SCP public partner network. We recognise that post has been vacant for some time, and it's really important that's filled as soon as possible. But longer term, with the strategic planning group, we're wanting to propose that they would lead an approach that builds more opportunities in the future and a stronger focus on succession planning. By linking the range of really strong lived experience groups that are already supported in the city, and thinking about how we can start to support people with lived experience through the strategic planning advisory group and then on the IJB in future years in a more kind of supporting constructive way, as well. And Martin, I think, was particularly about an advocate of that approach in terms of thinking more about succession planning and not just individual appointments as well. So we're happy to take any questions on that or queries, yeah, that's there for questions.
Thanks, Catherine. So the plan is a kind of two-stage process. So recruit an individual to this strategic planning advisory group, and then from there become a member of the IJB.
So that would be the longer term approach. In the first instance, we'll need to recruit someone hopefully through the public partner network to immediately join that IJB, because we have that vacant service user rep. So in the first instance, we need to think about doing that. But beyond that, obviously, the plan would be that that's how future appointments would be made to the IJB. So we'd work with places like the carers advisory group, the community health advisory forum, etc. All those really strong and well functioning kind of engagement and representative groups that we have in Dundee. And exactly what you say, support people who might want to become part of the strategic planning advisory group so that they get some experience and support there. With the hope that they want to go on to become IJB members in the future when the vacancies arise there. So trying to help people. Some of the feedback we've had is that going from not having any involvement straight onto that IJB quite an overwhelming experience for people, not for everybody, but for some people, in terms of moving straight into a formal public setting. And the few was that having opportunity to be part of the strategic planning group, where we have a wee bit more flexibility about how we can run meetings and how we can support people. And I think that would be a more helpful approach for folk.
And public partnership, that's an NHS.
And that's another reason to do a bit of changing, because their experience and expertise is really valuable. It's not necessarily as diverse as we would want it to be in terms of the scale and scope of the functions that are delegated to that GP in people's experiences of particularly social care and social work services as well as NHS health services. So trying to get a bigger pool of experience and diversity of views, I think would be really helpful to both the strategic planning group and the IJB.
And in terms of timeline, then, do we think we may have someone coming to sit on the IJB sooner rather than later?
Yeah, so just for IGB information, I've submitted a copy of the role descriptor but there's draft subject to today's approval to NHS this stage without the partners to see. So that is ready to step into that. So I identify the following today, so that's underway, but I just need to get it with my IGB as soon as I.
Thank you.
Yes, I will. Bob.
Thanks very much indeed, and thank you for the favour. Clearly, these issues are now timely, and I don't know whether they're questions or not, but really I think what we're currently conducting are the minimum requirements for both carer rep and for service user rep, and I think that's something that needs to be reviewed. When we look at other IJVs within Tayside that operate 2 carers and 2 service user representatives, that needs to be looked at, I think, and it would give us backup should there be any absences. Clearly, the absence of service user rep for a year, as you say, is unacceptable, and we need to have a better way of doing things. I think what's also clear, and as you know, Dave, I think you've referenced the issue about proxy voting. That's been an issue for the National Care Service Advisory Body, and around whether service user reps should have voting rights as well. And it's clear to me now that that seems to be a general direction of travel. The fact it's even got to a consultation stage tells us quite a lot about where the thinking is going. Now, I'm not saying in any way we should be advance of the thinking on that, but this strikes me now that the genie's out of the bottle, this issue isn't going to go away. So there's an issue about that for me. I think also we need to look at our own in-house and the key role for both representatives, carer and service user, is their role with the Strategic Planning Advisory Group. And I think that's the area for me where they really shine. And I think that's why we need to have some sustainable role there for that work. There is even a potential, in fact, Dave, for looking at future co-chairing arrangements, for example. So I do think this needs to be looked at, because it's more than just about filling a service user representative role. We need to think about where the future is now taking us. And I'd like these to be put into the mix and address these issues, I would say, positively. Thank you.
Thank you. Catherine, you'd like to come in? Oh, sorry, I was looking at this.
Yeah. Thanks, Bob. But just to say that I actually think the approach we're proposing would allow us to get to a position where if the IJB did want to consider the point you made around it just being the minimum requirement at the moment and more representatives in the future, that would get us to a place where that's more possible for the IJB to consider and think that you could fill additional roles as well, and also just to reflect that in the conversations we've had at the strategic planning group, some of your comments and the co-chair and doing different things have come up. So I think the strategic planning group will be keen to following the IJB's decision today, as it says, the recommendations to consider the detail and how we would do that. So we'll take on board your comments, but just to reassure you that actually the other people are thinking the same way within that group about it as well.
Thank you, Martin.
Yeah, just to reiterate what Catherine was saying about the strategic plan advisory group. A number of years ago, pretty much pre-COVID, that group had quite a few public members as well to that, and that was a good idea of getting them to move forward to the board, but unfortunately, circumstances like COVID rendered that from taking place. So we do have we should be really developing that group, not only that group, but we should be also developing representation of any planning group within the partnership, so that we've got a nice network of service users and care representatives. And we have a registered care advisory group that's very new in its establishment. It's a good time to really build up the numbers of that group. I think that will happen over time. So there's a lot of stuff that can be developed over time, and I think it's going to be a positive thing for the board and for other parts of the partnership.
Thank you. See any other answers? It's a great shame that we haven't had a service user rep since October 2024, and hopefully this paper will, and the actions which flow from it will speed that process up. I do wonder if there's a wider issue to make people reluctant to get involved in public life, although not health-related. Community councils, for example, struggle, and they have an important role in their community, like in terms of statutory role and planning decisions, for example, and one of the bigger community councils in Dundee recently folded. Didn't fold, but it almost folded, and one of the community councils in my one ward almost folded because of the lack of people coming forward. So yeah, I don't know what could be done to make the position more attractive, because I think being able to have influence is attractive in itself, but clearly that hasn't worked thus far. So hopefully, as I say, the action floating with help.
I'm going to come back to you on what you said there, not as a care resident, but someone who was involved in community council, who was involved in tenant groups. The discrimination that Dundee's effect has had over the last 20 or so years, there's been a gradual decline in the energy that people have, experience that people have to be able to do these sort of activities like community council, and it has caused them to help a community council, for example, collapse a number of years ago. They established a forum just to keep something going, to keep something active there. I think that's something which generally Dundee do have a big problem with. I think it's something that needs to be addressed as a major issue within local authority through the community and development aspects and seeing how they can help develop new groups and new structures.
Thank you, Mark. So, can we accept the recommendations from 2.1 to 2.5, please? I'm always just saying, I'm really not in favour, and I see what you're saying, so thank you for your recommendations.
Okay, so that takes us on to item 7, Protecting People Committee Annual Report 2024-25. I have this for noting.
Yeah, and I think I know Pamela Dudek here. I had the pleasure of hearing from you at a recent council meeting as well. I wondered, would you like to say a few words in reference to this year's report?
Yes, good morning. Good morning to you all members. I'm delighted to be here to present this report. I'm the Pamela Dudek, the independent chair of the Alcohol and Drug Partnership in Dundee, and Elaine Torrance is the independent chair of the Adult and Children's at Risk Committee. Unfortunately, she can't be with us this morning, but she's given me a few headlines that she wanted to pull out. So if that's okay, Chair, I'll just maybe take 5 minutes and then happily take any questions. I think, really as independent chairs, and also with Anne Hamilton as our strategic advisor around violence against women and girls, we really welcome this approach and this multi-agency reporting and the plans that are underway and developing in terms of how we integrate further to protect those most vulnerable citizens in Dundee, individuals and families, and indeed our communities. So for us, this is a really
important report. At the moment, it takes account of adult support and protection, child protection, violence against women and girls, and suicide prevention, and the ADP, the Alcohol and Drug Partnership. MAPA reporting on community justice remains independent at the moment, but we are working to how we can incorporate that in the future too. So the key word is integration. The key word is really, the key principles are about us trying to do things once with individuals, families and communities, rather than different parts of the system repeating the same activities around these complex kind of situations. And I think we're quite heartened with the work so far in terms of seeing some of that progress. And an example of that could be the co-location of the team in Seymour House, which has already shown improvement in how the teams work together and how they get around the individual rather than perhaps moving people around from pillar to post, which of course is the worst possible scenario. The common groups, so we have a number of common groups within the public protection structure now that cover things like prevention, so early intervention prevention, and things like quality assurance. And actually one of the subjects you've been talking about, how do we get the voice of individuals and families and communities at the centre of our planning, our strategic direction, and indeed any implementation that we take forward. And I guess that's underpinned by quite a lot of activity around a human rights approach. And indeed within the Alcohol Drug Partnership, we now have the Charter of Rights that was launched last December, that really puts a focus on how we work with the individuals, families and communities, and particularly the duty bearers' requirements in terms of meeting those rights. And we think that's really important right across all of public protection. But that does mean we need to make sure our workforce feels safe and understand how to work in that space. And again, most people do, but they need supported to be able to keep things right. And there's a toolkit there for us to use, and we will be doing that. The pathways around adult protection and child protection have a lot of scrutiny, and there is a lot of quality assurance work and learning underway, and some areas of positive improvement have been around chronologies and risk assessments. So really the focus there around those committees is very much about joining up, understanding where we need to improve, and then trying to drive those improvements through strategic direction, and then addressing the kind of implementation gap. What else do we need to do to make the right thing easy to do? In the ADP, we are really pleased that we are fully compliant with all the MAT standards, now described as we are green on MAT standards. That doesn't, however, mean we're in any way complacent. It's great that we've got all the right inputs happening and responses happening, as we should at this stage in the implementation of those. However, our focus is on outcomes. What difference is that making? When will we start to see the impact of that? And that is a national focus as well. Harm reduction methods remain really important to us, given the level of drug and alcohol deaths that we see. And we are trying to understand the changing drug trends, which are fast and furious and quite different from how they've been traditionally, and to try and stay on top of what we can do additionally that would again make a difference. So a huge focus on that. So I think those are kind of some of the main things that I'd want to pull out, but the working together, making it happen, bringing about meaningful change that we will see on the ground for both our workforce and our citizens and their families is the key focus. And I think we need to pay tribute, and we have as chairs, to our staff who work in complex and challenging situations every day. But when you go and speak to them, the motivation and the commitment is evident in abundance. But sometimes the job they have to do in the navigation, they have to try and establish is difficult. So I'll stop there and I'll do my best to take questions, but there are others in the call who are closer to the adult and child protection agendas and perhaps sit on those committees. Thank you.
Thank you. As Ken said, we already had this report at Dundee City Council, and I'll say now what I said then, a really good report. I like the way it was laid out, it's very user friendly. It's like how the data is presented at the back of the report. I have one wee question on the data on the second last page, if I may. This is the Alcohol Drugs Partnership. And you talk in this data about drug-related deaths, and you talk about alcohol-specific deaths. Can you explain the difference to me, please?
I will try my best. This is what I could do with a public health consultant. He's probably much better with the data definitions than I am. But I guess, you know, the related death aspects usually has probably multiple factors that can contribute to how the person came to pass away, but drugs would have been a strong factor in it. The alcohol specific would be when we are able to be clear that that was the key factor that led to death. So I think that would be my simplest way of describing that, and hopefully accurate, but there may be others in the room who would be better at that than me.
I'm happy with that, thank you.
Bob, you hand up to Bob Benson.
Thanks very much, Chair, and thank you, Fowler. And I really want to commend the areas of progress in 4.2.1 and 4.2.2. I think that's very heartening, and I can tell just by the way you presented that you feel quite heartened by that as well, actually. So thank you for that. And I noticed the establishment of new committees, and around children at risk, adults at risk committee, and the alcohol and drug partnership. How is the effectiveness of this committee structure monitored? Is there an inspection process that happens to ensure that they're doing the job they're doing? And I just wondered if you could start off with that question.
Yeah, absolutely. So you'll see that all those committees report into the chief officers group. So the chief exec of the NHS, the chief exec of the council, and the chief commander of the police are the accountable officers for everything that happens, public protection, and that group has the chief officer of the IJB, chief social worker, chief nurse. It has, you know, a number of key leads and professionals. So the scrutiny of what is going on happens there, and obviously we come to committees like this where we can again be scrutinised by yourselves. The independent chair role, of course, is to challenge and to take that step back from what's going on in all these committees, and to try and also bring some, I guess, grit into the mix to ensure that we are, you know, holding up a mirror, being accountable, and understand what we're doing. But Catherine, I know, is in the room, and she probably will be able to say a bit more. Catherine Sharp.
Yeah, and your hands up, Catherine. This is Jenny, so I'll take it from you.
Okay, thank you, thanks Pam. Yes, so just to add to what Pam has said, there is also elements of inspections and regime of the joint inspections for protection services that are generally carried out by the Care Inspectorate that alongside Health Care Improvement Scotland and DH&SCP. So people will recall not that long ago we had an adult protection inspection, and it looks at leadership arrangements, so it'll look at arrangements for the chief officer group and also for adults. I say prior to that, it was the same around child protection, and we expect there will be other inspection activity moving forward. So that leadership element is always a key element of those external scrutiny inspections. We do a bit of self-evaluation around the committee structure, and particularly since we've been changing that. So in the past, the improvement service has helped us to do some kind of development OT type sessions with the committees where we're trying to take a step back and think about how well things are working. And we certainly had a session last in June and the summer, just to reflect on the new structure, as it was it working as well as we thought it would in terms of the changes we made and the ambitions we had for that too. So there's quite a lot of different elements internally and externally having a look at how effective the committees are.
Thank you for that, if I may, Chair. Because obviously there's a whole lot of joined up agency working that is probably quite intensive, I should imagine, and behind the scenes in all of this work. But one of the things I did pick up was that the new Dundee and Angus Joint Learning Review Guidance, and that strikes me as a very positive approach to be taking. Does this suggest, Pamela, that a kind of hand-Tayside approach is probably called for here, given the interrelationship between all of these agencies and the sharing of resources? And I wonder what your perspective on that would be.
Yeah, I think so. I mean, the learning reviews are an excellent use of time and effort to understand what's going on in your system, and as well good practice as well as where things haven't gone well. The pan-Tayside aspect of that, my a very clear message through chief officers is that where it makes sense to do so, we should be trying to do things on a pan-Tayside basis. However, there are really discrete aspects to each of the areas. The geography is different. People aren't necessarily different, but the geography and communities are different. So you need to find that balance between the two. But policy wise, if you've got a good, clear policy, it's reasonable to share that. In fact, not beyond Tayside, actually, consistency is important when you're dealing with people who are experiencing complexity. I think the clearer and more consistent that we are in this space, the better for everyone, including staff who have to implement.
And thank you very much indeed. I'd love to talk more about this, but I'll leave for just now. Thank you so much.
Do you still wish to come in?
No, Catherine's covered quite much more articulate.
I've kind of made a resolution, like if someone puts their hand down, not to check, because you almost always put their hand down for a reason. So if you put your hand up from now on, anyone, and then take it down again, I wouldn't double check. You make sure. I don't see any other hands. There's so much important work is going on here. Really, over the moon about the fact that we've achieved green and all of that standards, because that was a huge issue not so long ago, but we're doing so well. You've seen improvements. It's great that we're green and all of that standards, but there has to be like outcomes from that. We need to see drug deaths go down, and we have seen drug deaths go down. We've seen suicide levels go down. We've seen alcohol-related deaths go down slightly, which is good. And I would hope to see the line on the graph becoming steeper, so that we see greater and greater improvements more quickly, because that will save lives. Thanks very much for your presentation today. That obviously is worth noting, and thanks for coming along.
Thank you very much. Thanks a lot. Yeah. Thanks.
So that takes us on to item 8, which is the Chief Social Work Officer and the report. You have this one, Walter.
Okay, I will present that. Unfortunately, Glenn is unable to speak here today. He's giving evidence. Got a number of colleagues here and have many questions. So people will be aware there's a legal requirement of a Chief Social Work Officer, and their job really is to provide professional and strategic leadership. There's also within the guidance and education that they should provide an annual summary report outlining that for local authorities and IJB. So this is this year's report. Quite a bit in the report, and happy with colleagues to answer the questions, but I'd probably draw your attention to some of the work we've been engaged on through this year. So we've been responding to a thematic report of governance, and we've had our first strength and practice event, and hopefully that will become an annual event. We've introduced a newly qualified social worker scheme embedded that, and we're also working on supervision and support framework, and in particular the adults at risk pathway. Challenges and opportunities going forward, obviously the National Social Work Agency and how we respond to that will be a significant part of the work next year. And we're also working, we'll be continuing to work through supervision and supporting adults at risk. Happy to answer any questions in relation to the report.
Councillor Laws on go. I don't think I have any questions. I don't know if any. But Dorothy does, yeah.
Just because we've had this at council as well, and good report, glad to receive it. There's a section highlighted on unaccompanied asylum-seeking children. It was highlighted in my printed copy, and it concerns young people newly arrived in the city via the National Transfer Scheme. And it says the service carried out an age assessment on a further 25 asylum seekers. Is there a difference between the definition of adults and children between Scotland and the rest of the UK?
I am going to defer to Alison on this, I think.
They seem to have been classed as adults, and then when we assess them, some of them as children and young people. So I just wonder, is there a legal difference in the definition of adults?
Yes, I can answer that question, and that is a good question and reasonable question, although I think it's potentially an error that paragraph remains highlighted. So the process that happens is that when the young people arrive in England, they are subject to a very initial risk assessment at that point. Decisions are then made about where they would go to within the country. There's then an expectation that once they arrive in our areas in Scotland, we would consider whether there needed to be a further age assessment. And across Scotland, we have numerous examples of young people who have been identified as being adults, who then subsequently on arrival in Scotland will tell us that they're under the age of 18. So the definition we're going by is young people over the age of 18, but it's not uncommon for young people once they get into Scotland to say, no, I'm not over 18, I'm under 18. So it's not unusual for us to then to have to undertake risk assessments on young people who have already been subject to age assessments on arrival within the UK.
Okay, thank you. So there isn't a difference in definition. It's just
No.
how the assessment's done initially and then further down the line.
It's a process issue, and it's a very rapid assessment on arrival into the UK, and then quite often young people will tell us a different age once they arrive in England, once they arrive in Scotland.
David, Chief, you had also.
Yeah, thanks, Ken. This was actually a really, I could use the word really humbling report to read, actually. Just at the very start of it, I couldn't believe the figure on child referrals, on child protection referrals. I mean, to be frank, I was ignorant of that sort of level. To find that in Dundee, we're talking about a 10% increase to 163 on average child referrals per week. You hearing me okay? So you're all back in the room now.
Sorry,
Okay, no, I'll just go back and I was just saying that I found this report very humbling and was surprised to hear of the large number, significantly large number than I would ever expected of child protection referrals in Dundee. And the fact in the last year they've gone up by 10% to an average of 163 per week, which was really quite shocking. Certainly to me, I had no awareness of that whatsoever, to be frank, and it does concern me. But the full report, very informative, but I say humbling is the right word that I would take. Was concerned a bit about the figures I see in absences here, and saying that they're markedly above the Dundee average here, and the bulk of it's down to mental health. And I just wondered if there was any further insight on that causes, particularly, rather, because I did read the follow-up paragraph showing what's trying to be done to deal with that, and employee well-being, of course, is a priority, but just really the causes that are making the level of absence in social work so high.
Yeah, we have done some analysis, and from what we've seen so far, it's predominantly around people's own circumstances, their finances, sometimes it's the time of year, but predominantly it is personal reasons. There is an exceptionally small number of staff where it is work-related stress, and then we would put measures in to support them. Where it's personal reasons, we try to signpost them to things like welfare rights, etc., counselling, to support with that.
I could probably just add on to that, that reflects what we see in the general population in terms of an increase of referrals into mental health services. So we've seen an increase generally in the population in mental health issues, and that's reflected in their staff group, unfortunately.
Oh, yeah. I can't remember what said, we've got roughly a fifth of the population on antidepressants or medication for anxiety. I think it's 22.5%. So yes, I'm surprised by that kind of it's all parts of the city and all professions. Not good though. Bob.
Thanks very much. I don't often deal with childcare cases, but I think the Chief Officer recently circulated an advisory on an investigation. I think it was judge-led across what had happened in childcare in another part of Scotland recently. And two of the issues were around about children and families that were moving between one local authority area and another, and how difficult that was to pin down accountability and responsibility. But the other fact that was more glaring in many ways was there were different assessments of the identification of neglect and deprivation in those children. And that struck me as being quite an important issue for social work professionals to have to really address, as if there's no common standard in terms of understanding of what deprivation and neglect looks like. So I thought I was struck by that. And sometimes I think from my own experiences of just how sometimes you live in certain communities where the norm is different from other norms, and that has an impact on your assessment. And I was thinking about that as well. In fact, if you relate that into adult protection services, do we have different senses of what need and deprivation is when we look at that? And I just leave that as an open question, because people's circumstances differ greatly depending on what their upbringing and lifestyle choices have been. What we do know is that people with disabilities and people with certain conditions have much more deprived existence than other people, and their access and understanding why professionals differs because of that. And I wondered if there's any just thoughts on that.
Alison, do you want to comment on that first, and I'll follow up?
Yes, sure. And thank you so much for that. That's a very insightful comment and observation. So yes, I think there's always a danger in a city with the demographic of Dundee that people can become desensitised to neglect. So we have to always be on our guard, and always to make sure that we're supporting our staff to be able to identify when good enough is no longer good enough for our children, and to not lower our standards because of the demographic and poverty and inequality issues that we're aware of within Dundee. So as a result of that, we have identified that as a priority in Dundee on a partnership basis. And I am leading on the development of a neglect strategy, and that's a lifespan neglect. So that's looking at that from pre-birth right through to older adults. And that group is well represented from both adult services, children's services and across the partnership. And we would hope to have a strategy in place by the summer of 2026. At the beginning of next year, we'll be undertaking a number of focus groups with staff to identify what their learning and developmental needs are. So we have examples of other such strategies across other parts of Scotland, and we'll be drawing on that. But I suppose just to say that neglect is an issue that is also identified as a concern on a national basis. We seem to have seen escalations and increases in this since COVID and since the pandemic. So it's recognised as an issue not just in Dundee but across Scotland. But I think we have to be particularly vigilant within Dundee. I think the other point just is in relation to children with disability within the context of child protection, and again on a national basis and from research, we know that sometimes child protection is not recognised as timely as it should be when we're working with families where children have disability. So that's a particular focus that we have with the Children with Disabilities, Children and Family Social Work team in Dundee, and we're doing some developmental work with them in particular, in addition to the more general work we're doing on neglect at the moment.
Thank you so much for that. If I may, a number of years ago, we did research in Disability Rights Commission on the life expectancy of people with learning disabilities in particular. And they demonstrated that people with learning difficulties had actually a lesser duration of life. And I wondered, do we have the data that can track this, not just in that area, but certainly for service users who also have mental health issues as well? Because often my experience is that people with mental health issues have other issues as well in terms of their physical health too, which often is seen to be a lesser priority than the mental health issue itself. And I do think it would be useful if we had the data that could help us to hear a bit more about whether our thinking is evidence-based in terms of where the real need is.
So probably comment on that these are issues in terms of strategic planning, both for adults with a learning disability and adults with mental health difficulties, and there's a number of actions that are in place within that to try and improve the physical health. And one of the things in particular that's looking into that would be things like your learning disability health checks. But both these issues are within our strategic plans.
Thank you.
Okay, actually, well, from the hands and more online. So thanks very much for coming along for joining us at any rate to speak to that, and which is promoting. Thanks.
Okay, so now move on to item 9, which is the annual report on labour partner arrangements. We've got this for decision.
Yeah.
I'll start off and I'll get Jenny to join me.
Yeah.
So this report, we have an agreement to the submission of the annual report with the partnerships and the partner responsibilities. And this is what was the first of those reports. There's a lot of information in there, and I'm not going to cover it all, but I've tried to pick out some of the key highlights from each of the appendices. So the first appendix is Angus services, lead services. GP out of hours, we've already heard from Jill this morning about the work there. One thing to note is that Dundee has the highest demand in terms of out of hours consultations at 163 per 1,000 population, in comparison to 120 and 100 for respective partners, neighbour partnerships. Speech and language, they've had improved recruitment, and there's been additional short-term funding identifying support heads and neck cancer. Common sense, they're currently reviewing options to reduce the demand-driven overspends. Forensic medical custody healthcare, they have introduced a new victim assault federal coordination service coordinator role, which alongside the new target operating model has led to improvements in outcomes. Appendix 2 is the Dundee paper for special palliative care services. We are making significant progress on the corporate objectives. There are challenges remaining with the current bed base not being fully funded, and we are seeking to shift the balance of care. Although it should be noted that Dundee is already in the top 5 performing partnerships for people spending the last 6 months of life at home or in the community setting. So our new HP consultant role has been exceptionally successful. We're doing further exploration of the skill mix. There's a new competency framework introduced for clinical nurse specialists. Our homeopathy service is, for governance purposes, is now reported under special palliative care service and will be reviewed and reported on through the wider palliative care review. Going on to Appendix 3, Jenny, and Short Highland.
Yeah, I suppose in relation, the challenges are very similar across the service areas that I found in terms of increased demand, increased complexity of demand and challenges across workforce. So in a number of areas, we are having to work really hard to meet waiting time targets. So you'll see in psychological therapies, we're meeting the target for 6 of the 18 services. Another 3 are achieving 80 to 90%. So quite a bit of work that's going in terms of we have improved recruitment of probably picked up nationally in relation to psychologists and psychological therapies. We have got some additional funding in there. We're also looking at innovation and increased ways of integrated working and digital improvements there. MAPS again, the multi-agency psychological therapy service, that's about improving access. As highlighted in relation to veterans, first they've achieved the Royal College of Psychiatrists accreditation. Challenges there really in particular within unstable funding models, so about 30% of the money comes to the Scottish Government and that's agreed annually. We have a number of new services that have been running since about 2021 in terms of perinatal mental health, infant and maternity neonatal psychology services. They're relatively new. Again, challenges in relation to the workforce there. Challenges in relation to the workforce in sexual and reproductive health. Yeah, probably not much to add in relation to that, but happy to answer any questions.
Thanks, Jo. I'll quickly go over Appendix 3 and then open for questions. So that's the Perthick and Ross report. Prison Health Service, they cover 3 sites. They have seen a significant increase in the number of COVID people, people with long-term substance use and mental health concerns. There has been several inspections which have also noticed this increase. They have a new clinical nurse educator and recruitment and retention remains a concern, but they're using GP locums and supplementary staffing to mitigate this. There is several quality improvement initiatives underway or plans, and they have a slight underspend due to those staffing challenges. The dietary, they have, again, with everything else, an increasing demand. They have had successful initiatives looking at the dietary-led vascular assessment service, first contact neurosurgery test of change, and there's a new shared care model with the community nurses in Dundee, which have all led to positive outcomes. Public dental services, this is a service for vulnerable people unable to access mainstream dental care and to promote dental health initiatives. And there's been several successes detailed in the paper. They also have a very slight underspend. Is there any questions?
Dave.
Not questions, it was just in terms of context for IJB members who've said this is the first time that we've had such a report in 3 IJBs. I think what we're working to across Tayside is a strength of partner governance arrangements, because I think if you go back over the years report, we've got to get the light on reporting in different kind of elements of services that are hosted that are kind of led by other partner bodies. Obviously today we had the flowers, we had to commit my health exception from Perth in the previous year. So this probably to acknowledge this isn't really perfect. There's a bit of an apology for the lateness of the paper, but that was because We were first in terms of the IJBs. We had to be on the other twos. Got their pre-agenda papers before we could submit our own papers. So obviously there's a lot of information in here for members to read at short notice, but we'll continue to work with colleagues on this to take this a bit slicker.
Oh,
Yeah, thank you. So a great report, actually. I mean, this is, as you say, this is the first, and just to see the detail of the information is actually quite fascinating to read, and to see what's happening across all three health and social care partnerships. I was taken to our own area where we have lead on palliative care, and I noticed that the challenges and risks around digital capabilities and financial implications in particular, and I see these as kind of key areas. But I'm equally taken with the need for more data analysis, and I just wanted to acknowledge that within the report is how important that's going to be ahead for evidencing need and making decisions from that. So thank you very much indeed.
I'm grateful for this. I've learned a lot about who leads on what. You know, that's clarified a lot of things for me. So this is really useful. I have one comment to make, and maybe you could answer it, Dave. In the Angus report, this is probably detailed. In the Angus report, overspends are put in brackets. In the Dundee report, underspends are in brackets. Now I find that quite confusing. Is there a standard accounting format for overspend and how it overspends and underspends? Because again, leading up to budget time, I'm drawn to financial information in these reports, and that's something.
challenge with the difference in how NHS presents its information and how Property City Council presents it.
Doesn't complicated even for us as accountants, and I'll have to look at it and think, are they reporting it the same way that we are, or the opposite way around? So
But there's no standard.
we don't understand those standards, local reporting ledgers and decision systems. It's just why it's very clear about whether it's overspend and underspend, and through the report to make that clear.
Yeah.
I haven't picked up in terms, I haven't actually spotted the differences in the appendices in terms of that presentation. So we'll try to make sure that that is a lesson learned.
The one is actually a great extension, but I'm really grateful for these.
No other hands, thanks. And we asked to note that the content on the basis, so that is agreed. And at this juncture, I'm going to call a 10-minute break in line with practice. 11:31. 11:31. If we could recommence, please, with the next item.
That's Chair, that's item 10, delivery of primary care mental health and wellbeing framework and an update of this for a decision.
Yes, and I believe we have Emma Lamont who's going to speak to this.
Hi there. Hi there. Thank you for inviting me. So this is just an annual update of the work of the primary care mental health and wellbeing framework. We have a strategic delivery plan that's well underway, and it has 3 main headings. Accompanying this update, can you hear me okay?
Yes.
Yeah. Accompanying this update is our first annual performance report. So I'd be keen to know if that detail in that report is everything that you're looking for in terms of format, etc. It has both operational and strategic information within it. Things to highlight within the update, the main priority, one of these is awareness and navigation, and we've had a number of initiatives over the last year, and we continue to work on awareness and navigation, ensuring that people know exactly how to access services and what's available through primary care and how that links into wider community services. It's also important to highlight today our priority around service delivery and development. The teams have continued to work really hard over the last year to provide and maximise the service that they offer. They have had challenges in terms of staffing, and that has impacted the amount of people they can support. It's causing an increased waiting time with the Socials of Support team. However, that has resolved now. PAMS, the Patient Assessment Liaison Mental Health Service, still continues to have some challenges in terms of staffing, which has been escalated and is being resolved as a matter of priority. But you'll see from the figures, both within the main report and within the update report, that the teams have actually seen a large amount of people and been able to support a number of people across primary care. And our partnership with Welfare Advice continues to grow and strengthen. And you can see that they measure impact by income maximisation for people. And you can see in the report how well they have done there. Another priority is around measuring outcomes and success. And we have been successful this year in developing a number of areas around this. So we've developed a governance framework, we've introduced primary care opinion into primary care. We still need to develop a framework on how we're going to promote that and build that database, if you like, of information that will allow us to collect significant information from service users and gain that feedback. We've established a quality assurance framework, and we've been working with the public health data team, and we've built and developed digital dashboards for each of the teams, and they're reporting into them monthly, and that's becoming really useful for analysis and reporting and monitoring, some of which you'll see in the overall report. We've also developed a set of key performance indicators, so they're currently in draft and they're aligned with our outcomes framework. And we have reviewed our inequalities impact assessment, which is attached because it'd been a couple of years since we'd done that, and there'd been a number of developments. The challenges are covered within the paper. I've probably covered them for you as well. And our priorities really for next year are looking at continuing to sustain and grow the service capacity. There is an increasing demand across primary care for mental health support, and primary care being that sort of open door first point of contact. We have made quite significant inroads around pathways for children and young people's mental health and building primary care as part of that pathway. And we do have a number of groups now that we contribute to and share information with. I'll leave it there. If there's any questions, I'm more than happy to answer them, and as I'm sure colleagues are too.
I thank you very much for that. I mean, my feelings on reading this very informative paper were twofold. My first thought was, my goodness, what a challenge we face. And I already mentioned the fact that 22.5%, as I thought, of people in Dundee, adults at any rate, were on medication for anxiety, depression or psychosis. It's actually 22.9%. So my goodness, what a challenge. But then upon reading the paper, my secondary thought was, there is a lot of work going on, and actually a lot of it's been recognised nationally. Distress, grief intervention, like the Police Department of the Year awards. Now, I don't want to go through all the awards, but clearly the work that's been done is achieving recognition. So yeah, mixed feelings, what a challenge, but what good work is going on. Are there any questions? Yes, Dorothy.
Not a question, just want to make a comment on the information on the welfare advice health partnerships and the impressive amount of additional income being brought in by the welfare rights officers and others based at DH&SCP practices across the city, and this is wonderful. People, we know well that worrying about money and how to put food on the table and pay the rent, has horrendous implications for mental health. So this is really good work. I think it's been recognised nationally as well, the work that's been done in Dundee. Marvellous.
Thank you. I'll pass that on.
Paul.
Thanks very much indeed. I agree with Ken. I think it's a really good paper to outline just what some of the progress is and the challenges indeed. There's quite a debate going on at the moment about mental health assessments, and certainly in the political world there are now debates around about, is anxiety an ongoing mental health condition, or what is it? Is it just a normal part of human life? And to what extent are these impacts of people who are referring and perhaps are on a waiting list for an assessment, determining whether they require mental health services or not? Because at the end of the day, as far as we're concerned, we have to deal with the demand. But I'm interested to know what debate is going on around about these different elements, because some of it's clearly benefit related as well. And just wondered what your thoughts were, Emma, on that. Clearly there are issues around just the vacancies and the health premises and the role of farms, etc. I get that within the report, but I do think there are bigger questions we need to be asking around about mental health generally. I just wondered what your thoughts were.
Yeah, and I think it's a really good point. So the PALM service, which you mentioned, that's the Patient Assessment and Liaison Mental Health Service. They're based in the GP practices. They are staffed by mental health nurses, and their role is to assess and triage. So they will see people once and make that assessment. That very question you've asked, how severe or impactful is what's presenting with the person? And they will refer on to psychological therapy, social work. They'll do adult support and protection or child protection, and they'll also refer into the community mental health team where it's seen to be severe. But one of the main roles that they also have is to refer into digital therapies or to signpost over to third sector organisations where they think that someone could benefit from, be it counselling, be it lifestyle support, be it other more low intensity. They will look at that initially, and they also, although they're a one-off appointment, they very much work on a similar ethos to GPs, which is try this and come back if you need more help. So kind of can do that stepped care approach and can scale up help once some of the lower intensity approaches might have been tried, counselling and social prescribing type, isolation type groups, and support that way. So yes, they very much are there to try and navigate that for people and make sure that those who are being referred on to psychological therapies or into community mental health teams need to be going in that direction. And maybe some of the other ways of supporting people have been exhausted. And we know around the other social factors around financial and housing and other areas that affect people, they would also be very keen to ensure that's being addressed as well through the teams.
No, thank you for that. And I think this whole issue about the demedicalisation of folk who are coming in with a range of different issues needs to be, I think we need much more evidence on this in terms of who are actually being diverted because they're not mentally ill in the assessment of a psychiatrist, for example. And so I'm just curious about how we handle this and how we sell this other approach, is that you're not medicalised for life, as it were.
Yeah,
because I think it really does matter.
Yeah, I think population education is really important. You know, we've heard from those working in psychological therapy services, for example, that someone may have waited on a waiting list and they haven't even been given advice or information about some of the lower areas, like, you know, having a good sleep pattern, not spending too many hours on your phones and screens and things like that. Some of these more basic fundamentals that everybody needs to know, but not everybody knows. It's not common sense for everyone.
Thank you.
Thanks very much for the presentation, and Can we accept the recommendation from 2.1 to 2.3 to note the progress, note the report itself, and ask the Chief Officer to provide a further report of this nature to a future IJB? That's agreed, thank you.
Thank you very much.
Item 11, which is winter plan, NHS Tayside, partner organisations, you have this for motive.
Carrie Ann Stephen, I believe.
Thank you very much, Chair. Hello everybody. My name is Carrie Ann Stephen and I'm a senior nurse for urgent and scheduled care in NHS Tayside, and I'm here today on behalf of Lynn Morman, Service Manager for Urgent and Scheduled Care, just to present the winter plan for NHS Tayside and partner organisations. This system-wide approach to winter across NHS Tayside and partner health and social care partnerships demonstrates a mature level of collaboration and shared leadership. The arrangements in place for 25-26 build on learning from previous years, helping to strengthen our operational resilience, escalation management and workforce planning. Key strengths that I just want to highlight within the report include proactive workforce planning, enhanced communication and engagement across partners, and continued investment in Home First, hospital at home and discharge without delay pathways to ensure our patients are in hospital for the right amount of time. And this includes improved use of data through system huddles and dashboards to inform real-time decision making. Also as well, just to note, we have had additional funding of approximately 4.2 million, which has been allocated to NHS Tayside to support delivery of the operational improvement plan, specifically aligned to the delivery of discharge without delay principles and expansion of the hospital at home. Dundee Health and Social Care Partnership has been allocated a proportion of this, which has helped support additional recruitment for delivery of a 7-day service and also provision of urgent frailty response in the community. Thank you very much, and just a brief outline, and if there's any questions I'm happy to take them.
Hi, thanks for that. So clearly one of the issues in winter is increased levels of sickness, in particular influenza, and we're already, well, going by newspaper reports anyway, BBC, very high levels of hospital admissions with, I think they call it super flu. I don't know if it's any different from, I know there are different strains every year, but it seems to be the message that this particular strain is quite a serious one. And at this stage, how much strain are we seeing on resources Tayside-wide as a result of this?
Thank you, Chair. So if I could just come in there. So yes, we are seeing that across our hospital system, and that's use of our data and our heat maps is showing that just now. So as a result of that, we are also very keen for all staff and members of the public who are able to get the flu vaccination. The pressure within the hospital system is extreme at the moment. However, due to the operational measures that we have in place and escalation frameworks, we've been able to mitigate that. So that's looking at escalation frameworks, and what has been working well is that enhanced communication and working differently across all our organisations and partners to ensure the patients that are within our hospitals need to be here. So yes, we are seeing that, but are reflecting on that and looking at how we're working, and the escalation huddles have increased. So we have had fairly recently a tabletop exercise, and again that was learning from last year. So now all these action cards have been put in place. So we're showing that is working just now with enhanced communication across all sites.
Thank you, Paul.
Thanks very much indeed, and thank you, Carrie. There's such a lot going on with this. I'm glad that Ken raised the question about influenza, and what I understand it it's well within capacity that we currently have, according to recent statements from NHS Tayside. So we seem to be handling it well. One of the issues you talked about is vaccination of staff, and I'm thinking about vaccination of health and social care staff in particular. Do we know what the current figures are in terms of percentages of staff who are actually vaccinated? And I raised the question because clearly we're working with a lot of sick and disabled people in care home situations and elsewhere. Do we have any of that data? Because I think that would help us quite a lot. Historically, it was quite low, as I recall. So that would really be an important issue for us, to knowing that staff themselves are protected and are not going to suffer unduly if they do get infected, as well as have to worry about being infected by patients, etc. as well. So I think that's quite an important question. I'm not expecting you to answer that immediately, but I think one of the other things that's regularly come up in IJVs is the issue around slips, trips and falls of elderly people in Tayside, which will have a direct impact on the services that you are providing, because they're around the house much more and there are things that happen, etc., or even going out in slippy conditions. So I wondered if there's any more you can say about that area of work and how we're helping to address it.
Angie, I noticed your hand up. Do you want to come in this bit, or?
Yeah, thank you.
Thanks.
So 2 things. In terms of the vaccination uptake, we don't hold that locally because it's not managed centrally. We don't have it ourselves. However, the vaccination teams have said that they do have some of that data within their database. So we're just waiting on information regarding that. Once we receive it, we will share that. In terms of the falls, every year there's a huge piece of work that goes on around falls. I know that in the care home sectors, they are already revamping their 2 elements, one about the multifactorial falls risk assessments, but also about the care for physical activities programme, which actually keeps people moving more. What we haven't been able to make huge inroads into yet is the more general population, and how do we actually get that messaging out to people that they need to keep moving. If people keep moving, they will have less falls, but it's a typical scenario in winter. They're sort of cozied into the house, they're not moving as much, so they do decompensate a little bit. So there's work ongoing to see how do we actually get that message out to the wider population.
No, thank you for that. And I noticed also this a bit of confusion about the role of hounds is within the paperwork, that it's seen as treatment rather than assessment signposting. And I think that should be a problem that we should be able to address fairly quickly, I would have thought. I just wondered what your thoughts were on that.
Is that a question directed at myself, Bob, or? Yeah.
Well, if you feel okay to answer it, that's fine. Thank you.
So are you referring to signposting for, for which area was it, Bob?
One of the key challenges.
So is that for signpost for PAMS?
Yeah.
Is that? So that's not my area, I suppose, of expertise. I don't know if Angie, you want to come into this bit? You can maybe help.
Yeah, sorry, I'm not quite sure I'm fully understanding the question, but
yeah.
The PAMS service is one of the mental health services that sits within the GP surgeries, which, apologies, Jenny's just had to leave. But my understanding is that it's a bit of both, a bit of assessment and also a bit of treatment. But I would need to get more information for you, Bob, and come back.
Okay, thank you.
Well, this item is one of the things. Thanks for coming, joining us to present it. And let's hope that it won't have too difficult a winter. Thank you.
Thank you.
Okay, so we'll move to development item 12. It takes us then on to item 13. Inside IJB service management strategy, and you have this for a decision.
That's very brief. We're taking endorsement of the updated version of the Inside IJB risk management strategy. This was last looked at about 5 years ago, so there should be an updated refresh. The changes are very minor. I think there should be very minor changes to word the terminology to refresh and bring it up to date. The overall structure and contents and the overall requirements remain consistent with the previous version. So there is a substantial change to report to you. It's just we'll have this completed as we kind of continue work to review and local arrangements for that strategic fish register will come back to the year because that's the overall framework that that's.
Dave, you want to?
Should I just start this because it's part of the day service works with team for the day service management, which has membership from the IJBs, the local authorities and the NHS day service as well. So there's a true collaboration, consistency across the piece. As Catherine says, it's going to be very minor changes to the previous version of this, and most of actually separate out the roles and responsibilities of the Health and Social Care Partnership against the IJB. So this is the IJB's management strategy. I'm going to review the previous one. There were areas that were kind of obviously covering both that were not appropriate. So this is a much kind of more defined document. So.
Can I just ask, we had an exercise recently to remember on risk appetite.
Yes.
Which I greatly enjoyed. So will that information or something be incorporated going forward? You know,
Yes.
the board's appetite for this.
Yes, so we're going to work on one of my days, we spent a bit of stuff around this, so we said it, that update of the IJB strategic draft register as part of that will be incorporated into this update that you previously said, and looking at the section of the report and reporting on that, because now we have a separate update that wants to report about this, and it's like it's right up on the Facebook page, packaging all that up in the back.
Okay, thank you.
Thank you. So that's the notes and approve what has Dave's pointed out or Catherine's pointed out, the relevant minor changes. Anyone opposed to this?
Item 14, financial monitoring position as of October 2025 is for voting.
Thank you. So yeah, this is the latest financial monitoring position based on the position at the end of October. The figures are showing a slight improvement from the previous reported figures and projected spend now on 5.273 million for this financial year. And that's about £700,000 better than the previously reported figures that came to you in October meeting. The underlying and ongoing demands include the demographics, the complexity of needs of the Dundee population. These are all the key drivers for our projected overspend, along with the unmet savings that we've had planned for this current year. As we've already sort of heard and probably already aware that the key variances remain in the care of old people care at home packages. We've got a lot of pressure on that to support the capacity and flow through the inpatient and the nine wells and our delayed discharges, and also in terms of that managing that care at home packages demand. We've also had also seen pressures on our housing adaptation spend, community nursing budgets, and the adult placements and packages. So all the sort of things that the IJB, the key measures and the key sort of strategic shift that we have, and that's sort of all of our pressures. But it's also worthwhile highlighting, as we just actually heard from Carrie, in terms of our winter plan, the continued performance in Dundee in terms of the delayed discharge remains really positive. One of the best performing areas in the country. To support people to actually remain at home or return home once they're medically fit to do so, in terms of supporting that capacity and flow. And that's also particularly important just now as we move into the winter months, particularly as Ken's highlighted in terms of the flu modelling there. So at this stage, while we are seeing that obviously that financial pressure in our budgets, we do remain in terms of the whole system in a good place. In terms of starting the winter from a reasonably strong position. The key points in the analysis of the variances are noted in section 4.3. Section 4.5 and appendix 4 provides detail on the current plan savings and the savings review. We're actually anticipating to be meeting around 82% of our planned initiatives from the £17.5 million gap that we reported as part of this year's budget process. This section also highlights the progress on the planned service reviews and some of the challenges in terms of some. Section 4.6.
Oh, hi. Sorry, the line's not up. very good. My name is Siobhan Toland. I work at the Disability Service, and I wanted to speak to you about a potential security issue.
Siobhan, the microphone's on.
I think. If she doesn't, I don't think she meant that, she's silent on it.
Okay.
I think someone's obviously just wondered or something unfortunate. Guys, sorry, carry on.
Yeah, sorry. Section 4.6 and Appendix 5 provides members with an update on the financial recovery plans that were approved in the October meeting. Obviously, as this financial information is based on the position at the end of October, the progress that we made from approving the plan to actually reporting these particular figures was relatively short, although the actions are obviously ongoing from the summertime. At this stage, the documented actions that we have continued to remain insignificant. We offset the projected shortfall in this current financial year, and we do continue to work across the partnership with all our services managers to improve the financial position through management of spending and delegated budgets. And so the IJB just asked to look at the place's financial position and the ongoing work to address the projected overspend for this year.
Thank you. First up is Martin.
Thanks, Chair. Just a quick question relating to this paper. I'd say you've pretty successfully been able to move and reduce the overall gap there over the period of time. But we haven't come to the last few months of the financial year. Do you feel you've got the ability to close that completely? And if not, how you started conversations with the DH&SCP for additional funding to fill that gap?
Yes, so the financial recovery plan that we have has also been shared with NHS Tayside and Dundee City Council. So that for our financial colleagues and the relevant sort of oversight groups the board are aware of the financial gap and potential risk share. So that's in their position and aware of it. You're right, we are running out of time in terms of the deliverability of this, but it's that work will be continuing, and we continue to step it up, and we also continue to be looking at that forward look in terms of 26-27 budget process and what we're actually putting into place now. That's going to mitigate the longer term sustainability issues that we actually have in terms of the financial position. So I'm hopeful, but also realistic that of where we're actually at just now. We're really mindful in terms of the whole system impact as well. There could be actions that we could be putting in place in terms of our own financial position to pull that down, but that's just going to make the position worse across the whole system for individuals on capacity and flow, and that's not what we want to be doing. We want to be pulling this down, but still maintaining or managing demand for individuals and families in the city.
Thank you.
David.
Yeah, thanks. It's good to read a slightly improved position here. It was just a more of a question. You referred to paragraph 4.3 there, but in 4.3.6 it mentions about the community nurse services projecting an underspend of 174,000, but then it says it includes an overspend of 556,000 linked to over recruitment and community nursing. So if it includes an overspend of 556, where's the big saving coming from to bring it to a underspend of 174? Because that's immediately a £750,000 turnaround.
So Dorothy actually picked this one up as well as a table question for me. So yeah, the net position of a number of services that are grouped in the appendix comes to 174,000 underspend, across which the community nursing, the HPs, other adult services, drug and alcohol services. So that net position is 174 underspend. The main area of the underspend is actually coming from the HPs. They've had vacancies through part of this year, which they've now in the process of filling. However, the overspend on the community nursing side of things is noted there, and that's one particular concern that I do have, and that obviously just reflects some of that community demand that's in which obviously linked through back into the care at home demand and the packages of care. So, well, we know we've got an overspend on care at home. We also know we've got an overspend on other associated services that also support people to remain at home. And that's why I sort of highlighted the community nursing overspend. But I appreciate perhaps the way that this is worded and further by that. I'll look at the wording of that to make sure it's a little bit clearer moving forward, that net underspend is a group of services.
Okay, thank you. Thanks.
Go
Um, page, key drivers of underspends and key drivers of overspends. I think this is a bit of a dilemma. Key drivers of underspends are staffing and vacancies, and key drivers of overspends are the premium cost of supplementary staffing. So, you know, what can we do, you know, to balance this out? You know, we've got staffing vacancies and we're filling them when we need to, with supplementary agency staff or whatever. You know, and it just seems crazy to me. Yeah. But that's the position you're in, and you have to staff your services. So what I know what's going on with this.
That's a kind of example as to why the community nursing overspend sitting there. So what we did when we realised that we were having to use so much supplementary staffing, we converted a portion of that to permanent posts so that we could mitigate some of the risk, keep a bit more control over that. And that helps to some extent, but because there's been delays in moving to the new locality modelling, for a variety of reasons, that's delayed us being able to bring that overspend back down again. So we are looking at that, we are looking at how we can be a bit more clever or smarter about how we use the funding to fill those gaps. But that is the reality that we're living with, unfortunately.
What is the premium for the supplementary spending in terms of the standard rate and the premium rate that you're paying? Can you quantify that in percentage terms? Or
I couldn't offer that. What I can say is that we have almost eradicated agency spend. There is a very small statistics because of the special nature of it. Does require agency periodically, but to a large extent we've managed to get rid of the agency spend, and it is about the bank staff coming through them else, which again keeps that down lower than it was at this point last year. But again, we're monitoring that, but I'll try and get those figures for you.
Yeah, no, just the question presented. I was just described that I think it's best of a good challenge for us. Going back to financial recovery actions that we've made, we have got items that enhance the vacancy management process. With part within that, we are making sure that there's a vacancy that relates to approach that require the professionals to cover plans for us to fill. So we're not checking our balance off, let's say we'll actually just pay extra. We are interacting, we're trying to make sure.
So within that sort of critical posts that would be included, where if you didn't fill it, you would have a premium.
Yes.
Yes.
Absolutely.
Cost. Okay. And can I just say one other thing? This is for board members. I hope you've noted the reserve position at the end of the financial year is general reserves 0. So we'll, you only spend it once and it's spent.
Bob.
Oh, thanks very much indeed. Actually, this is a really difficult balancing act, isn't it? Really, you're trying to achieve here. It's you can't make cutback scenarios because that has a direct impact on our delays to discharge and various other areas that you've talked about. So you're really on the horns of the dilemma here. I think the issue for us, given the uncertainty of where we might end up at the end of the year, is what kind of risk management are we prepared to accept as an IJV as we move forward? And if I'd been able to get to my paperwork in time to look at the risk management strategy, I think we need to a session on where we balance out these issues around about finance, delivery, workforce and quality, because they're all interfaced with each other. So we need to have a serious sit down in terms of what is our risk appetite around these areas, because clearly we're faced with these figures on a continuous basis. So what are we comfortable with, and what do we not want to compromise? And we've had various discussions where it was about alcohol and drugs partnerships and monies and things like that. So I do think we need to bottom out what is acceptable for us looking ahead here, because it's clear that I can't see how we're going to make these budgets work towards the end of the financial year, quite frankly, given the figures we have. So that's my thought on it, Dave. I do think we need to sit down and have a separate session on what is acceptable, what appetite do we have to cope with in all of this. Thank you.
Yeah, no, that's all kind of good point. And what you're describing there is this from the NHS at the moment is how Nicky Connor describes the what people do and try to balance up and across all those different elements that you've mentioned. I think in terms of our budget development sessions, I think that's something that we will need to kind of focus on. And so, you know, a view as a board when we're looking at the various options that we put to you, obviously we can look at the qualities of impact, etc., but we need to be very clear in terms of impact on the kind of quality of staff and performance, etc. as well.
We have that to look forward to next week.
Could I just say, you mentioned just that earlier, we did have a session on that, but I think that's a good idea because this is the reality we're facing now. So we might want to adjust our risk appetite or make it more real. You know, so I think that's quite a good idea.
So yeah, that's for voting. Next item, please.
Item 15 is an agenda on the 26-27 budget update, and it's for voting.
So just a very brief update. We brought on a budget, the detailed budget paper to the IJB in October, and we're going to follow one around the session the following the end of October. The budget timetable did include that an update brought to the December IJB. However, at this stage, it's just pointing out that there's actually no material changes to the information that we previously presented. We're continuing, obviously, as officers, the management team, to be working through the options, opportunities, and applications for proposals that will allow the IJB to be setting a balanced budget for next year. We do have another budget development session next week, so we'll be looking at some of the options and that risk appetite and implications at that stage. So it's just that noting that at this stage we have no further changes to the underlying assumptions and the figures that were previously shared.
Any questions? Next item, please.
Item 16, financial regulations 25-26. This is for a decision.
Okay. Yeah, so the financial regulations are subject to an annual review by ourselves. The financial regulations provide that financial governance framework within which the IJB will operate to ensure we've got appropriate systems and controls in place. And the IJB's financial regulations work alongside the partners' standing orders of financial regulations of the Dundee City Council and DH&SCP side as well in terms of the operational delivery of aspects of it. So this incorporates this annual review of financial regulations document, and IJB has to note that there's no recommended changes to the existing document and to approve the continuation of the existing regulations.
I have no objections. Does anyone else have an objection to adopting these updated regulations? No, thank you.
Item 17, scheme of delegation 25-26 is for a decision.
And similar as well to financial regulations, the scheme of delegation setting out the powers that can guard with the IJB and delegated responsibilities from partners. It also contains details of the remit and responsibilities of the Chief Officer, Chief Finance Officer, and Chief Social Work Officer in terms of the operational management and deliverability of integrated services. This is again subject to an annual review, and IJB are asked to note that there's no recommended changes to the existing document and it's this continuation.
Okay with everyone? Yeah, thank you.
Item 18 is meetings of the Integration Joint Board. The attendance list is attached for information. We'll just carry on.
Yes, please, yeah.
Item 19, IJB development session, as we've already said, there's one scheduled for the 17th of December. Item 20 A and B is programme of meetings of Integration Joint Board and Performance and Audit Committee for 2026. These okay?
Yeah.
Yeah. And item 21 is date of next meeting, which will be held in a hybrid format on the 18th of February in this room and remotely.
Yeah. Thanks very much for your attention. For those of you who want to see the budget session next week, hope you have a really good Christmas and Happy New Year when it comes. But I know a lot of you will see next week for the joy of talking about the budget again. Thank you.
Thanks, everyone. Thank you.